It is 12 p.m., so let's get started. Good morning, everyone. Welcome to Discover with UH. My name is Olivia Larby. I work for the Clinical Research Center and our Research Integration Education team, and I am so lucky today to have members of the Harrington Heart and Vascular Institute with us today to talk about their research and everything going on in cardiology research here at university hospitals. Just a reminder for you guys, this webinar series is a quarterly panel discussion dedicated to exploring the intersection of healthcare, clinical research, and health equity. These discussions shine a light on researchers and research staff across the UH system and the great work they're doing towards advancing science and medicine. Today, we are turning our focus to the Harrington Heart and Vascular Institute. Screen. And since the And since the 1930s, the Harrington Heart and Vascular Institute has been pushing the boundaries of medicine to benefit our patients here in cardiology research at university hospitals. Today with me, we have three researchers from Harrington Heart and Vascular. We first have Stacy Mazurko, BSN, RN, and CCRP. She's Director of Cardio Oncology, Clinical Trials Unit, along with a few other departments here at Harrington Heart and Vascular, and loves community outreach and traveling. Stacy, I actually wanted to ask you, where do you do your community outreach in Cleveland?
Sorry about that. We actually go across the UH system we try to go to underserved areas, but we do outreach pretty much anywhere, all over.
Nice. And this is with HHVI as well?
Yeah, within the Harrington Heart and Vascular Institute, and I do some personally as well, yes.
Very cool. Thank you for being here with us today, Stacy. Next, we have Dr. Mehdi Sushibor, who is the president and the Angela and James Hambrick Chair in Innovation of the UH Harrington Heart and Vascular Institute. According to Dr. Sushibor, he is a beekeeper and also has a chicken coop. And I was wondering, Dr. Sushibor, how do we go from medicine to farmer when we get back home?
Believe me, in the winter time is not fun because the water freezes and the poor chickens, they don't get enough feed and water. But is to keep me insane and to keep my sanity. I do the beekeeping and I love my chickens, and especially the eggs are the best.
Oh, okay. I've heard good things about like home chicken eggs. So good to hear. I'm sorry that it's such a snowy day. I'm sure your chickens are not having a good day today.
Well, they do have a heater. We keep them warm. These are spoiled chickens. We call them. They do have a heater that we put for them, and once in a while we actually make them oatmeal, which they love.
Oh,
So we do take care of them.
those do sound like very spoiled chickens. I'm sure they're living the life. Well, thank you for being here with us today, Dr. Shishibor. And then lastly, we have Dr. June Lee, who's the co-director of the Vascular Center and co-director of the Pulmonary Embolism Response Team, who loves photography and traveling. And Dr. Lee, I was going to ask you, on this snowy day in the dead of winter, where would you like to travel to the most right now?
Somewhere warm. We're actually going to Hawaii for spring break with the kids, so I do look forward to that coming up in March.
Oh, have fun, enjoy. I don't think I've been to Hawaii in many years, so hopefully you guys have a good time.
Yeah.
Well, thank you, Dr. Lee. Thank you to all of you for being here with us today. We're going to start off with a few questions that we have here at the Clinical Research Center. But for our audience today, if you have any questions that you'd like to ask our panel of HHVI researchers today, you most certainly can. Please put those in the Q&A and we'll get to them later on in today's discussion. But let's start with some of our questions here today from the Clinical Research Center. And I actually want to start with Dr. Shishibor and ask you, how does the Harrington Heart and Vascular Institute differ from other cardiology programs across the country?
Yeah, thank you so much, Olivia, for that question. There's, we can talk about this for a few hours, but, let's link it to research, which I think the conversation today, I think that, one of the things that makes us very unique here is our collegiality and team-based approach. And as you know, when it comes to research and innovation, a main ingredient is being able to cross discipline and be able to get very innovative and academic people from different areas to put their mind together and be able to create something special. And that's what I think we do very well here, because we have a lot of multidisciplinary teams coming from different backgrounds: surgeons, interventionalists, vascular medicine, cardiologists, and also we are very willing to collaborate outside of our institute. So we reach out to people in emergency medicine, in dermatology, in pulmonary critical care, and collectively, we are able to ask questions that maybe if you were just doing the research in one silo, you would not have all the knowledge to be able to ask the right questions and also answer those questions. So yes, I think that has allowed us to be very creative by being multidisciplinary, working in team format, reaching across the aisle, and that has been very productive for us. I give you a quick example of this is honestly is our Limb Salvage Advisory Council. And that's the program, we call it the LSAC program. And now that program has significant clinical implications, but also has had a lot of research implications for us. And Dr. Lee is also very involved with that. And that program, for example, includes vascular surgery, interventional cardiology, vascular medicine, podiatry, and even reconstructive, plastic surgery. So, and collectively, we were able to get a team together in 2019 to create a program that has significant clinical impact, but also we were able to publish our work, and there are now other institutions that want to emulate and kind of create a similar program to be able to save limbs and help their patients locally in their region.
Thank you, Dr. Shishibor. I love to hear that. I love to hear that collaboration, especially how much it relates back to our mission, vision, and values here at UH as well, that you guys are collaborating with so many different teams. So thank you for that response. Jumping over, Dr. Lee, talking about heart health in general, how you guys are working with it at the HHVI. What are some common misconceptions that people have about heart health when they come to you as patients or even as caregivers here at UH? And how is clinical research starting to address some of these misconceptions?
Yeah, and that's a great question, Olivia. And it's something that we can, we've noted, especially in the last few years, is that if you look at the diversity and the inclusion of patients in clinical trials, underrepresented minorities are typically not actually recruited in clinical trials. And women are actually usually underrepresented as well in most clinical trials. And it's across the board in every subspecialty, even within cardiology, outside of cardiology. So the question really is, why is that? Is it because we're not approaching the right patient? Are the patients not interested? Are we even asking the patients? Are we self-selecting the patients targeted for inclusion into clinical trials? It's so important to ensure that we have equal representation in our clinical trials, because these disease states occur in everybody. I would just use vascular disease as an example, because that's something that Dr. Shishibor and I are very passionate about. We know that in the Black community, peripheral artery disease actually has a higher preponderance compared to Caucasian patients, and the same for Hispanic patients. But unfortunately, they're underrepresented in treatment. So in present treatment, so when patients come in, they are either not diagnosed with peripheral artery disease or it's underrecognized, and they present really, really late, to the point where we cannot even save the limb. And the same thing actually is then translated into research as well. The patients that are recruited into studies are primarily Caucasian patients. And that's a huge gap that we have to fulfill. So we have to attack it actually from multiple aspects. Number one is public knowledge, right? So we're always trying to, with multiple societies throughout the country and internationally, trying to promote the knowledge of peripheral artery disease and the preponderance of it in patients that are outside of kind of the usual patients that we see, and really address the deficiencies in treatment for these patients. And then secondly, when we do see these patients, include them in the recruitment for clinical trials. That's why it's important to study these equally across all ethnicities.
Thank you, Dr. Lee. I love what you're touching on there with the just wide amount of disparities that we sometimes have in healthcare and in clinical trials. And that leads me into my next question. I'm actually going to pose this to everyone. Maybe we can start off with Stacy on this one. You were talking about some of the barriers to getting involved in clinical research and on those protocols, and involving participants or potential participants in that. What advice do you guys have for other research teams in the Northeast Ohio region on how to break down some of those barriers, get more equitable representation in clinical research, starting with Stacy?
So I always like to tell people to think outside the box, to see whatever it takes to get the research patients, meaning go where they are, listen to what others you've learned from others. It's important to have engagement with the physicians, with the nurses, with the other teams, and not to focus on just one population, but all areas of population.
It's interesting. There's actually a push from the FDA to perhaps include more PIs that are of different ethnicities, different races, different sexes, just to really promote diverse recruitment of patients. And there has been some hypothesis that perhaps if you have PIs that are not all Caucasian males, that perhaps your inclusion of patients will be a little bit more diverse. So that nationally, that's actually the move is to include more PIs on a local level that are different.
So having a more diverse workforce as well to encourage more equitable recruitment.
Yeah, I would say the other thing that makes us very unique here, Olivia, and allows us to have this diversity is that, a lot of times for that diversity to happen, we have to go to the patients. And a lot of the research happens at the major medical centers, which not necessarily may be in the right location to attract that diversity. We are obviously unique here at UH because our main campus does have a diverse population. But beyond that, we have done an amazing job under Stacy's leadership to create a research program and infrastructure that functions across Harrington HVI and across Northeast Ohio. So, for example, when we conduct a project, it's not just at the main campus at CMC at the Academic Medical Center. It extends all the way west to Elyria and Parma, and goes all the way east to Geauga and Portage, and goes all the way south to Portage and Samaritan. Like, we have a very broad research infrastructure that's been created by our team here under the leadership of Stacy and Dr. Mackel, and that allows us to bring the research to the patients rather than hoping that the patients are going to show up to you at the main medical center. And you asked me, your first question was, how are we different? Well, this is one of the things that differentiates us, that we go to the patient and don't expect the patient just to come to us. We make it easy.
Thank you all for answering that question as well. And again, going back to that mission, vision, and values, and making it the easy experience for our patients as we can. I really appreciate hearing that sentiment, and learning about how widespread your program is and how you're reaching out to patients at different locations. I do have a question kind of shifting away from the development of the research, how we are reaching our participants, to the research itself. Let's shift over there. Stacy, as the clinical trials director, I'm sure that you are working with study teams throughout the system and on quite a few protocols yourself right now, and have throughout your career. And I want to know, what research have you been most excited to work on with HHVI throughout your career, or what projects have you been most excited to develop with principal investigators, and why?
So I've seen a lot over the years, and 25 plus years in clinical research. I've seen, and mostly cardiovascular, but I have seen, devices be developed, drugs, different procedures. But I would say that the thing that I'm most excited about, and I think the most impactful for me, was when we established our TAVR program and started doing clinical trials with TAVR procedures, and that's transcatheter aortic valve replacement, where it really changed the landscape for aortic stenosis disease. And I think the other thing that it did was it also gave us more of a unified approach of collaboration with both our surgeons and our interventionists, and really more of a personalized approach with patients. To me, that was transformative. It really solidified how important shared decision-making is and the importance of a personalized approach with patients. And that was back in 2011 when we first did our first TAVR procedure here. And I think the impact, you know, my why I do what I do and my passion is because it's seeing patients that have untreatable disease or no other options, and then we can make that difference, whether it's a drug, a device, a procedure, and it changes their quality of life, extends their life, gives them more time with their family. And those, to me, have been the most gratifying moments of my career.
That's really great to hear. Kind of going off what you were saying with some of these, with TAVR, really, this device you're talking about, how has in the past 10, 15 years the personalization of healthcare for your patients, how has research been impactful in that, continuing off of where TAVR started and continuing to the past 10, 15 years since then?
So now that the actual TAVR procedure is FDA approved and we do it, you know, routinely. When we first started it, you know, when we did our first case here, there was 35 people in the room, medical professionals in the room, and now there's probably 5. And we're doing 2 or 3 cases a day. Patients, you know, I'll quote Dr. Simon, he says we do it in the awake and talking patient, which it really has been transformative to see, because in the past, patients, they had no option or they had to have a surgical valve replacement, and now they're being able to have this procedure, less invasive, decreased length of stay, better quality of life, you know, less recovery time. So that's been transformative.
Thank you, Stacey. Thank you. Shifting over to Dr. Shishabor, how has your research focus kind of developed and changed over the past 10 to 15 years as well with new advances? And what are some of the advances in interventional cardiology that would have been unheard of a decade or 2 ago?
Yeah, you know, the great questions, you know, to be honest with you, we are, and I saw there was on the Q&A, somebody was asking about AI and you know, machine learning and so on and so forth. And I saw Dr. Lee was responding to that, and we can talk about it more because, as you know, this is a huge impact, you know. So like any field with cardiovascular, we are continuously evolving, right? There are new innovations, new devices, new strategies, new equipment. As Stacey mentioned, you know, the era a decade ago, it was the era of percutaneous heart valve. I mean, the idea of not having to do a sternotomy and crack someone's chest to do open heart surgery to replace their heart valve and be able to do it through a catheter through their groin and be able to do that procedure and they go home the next day. Like, who would have ever thought about that? Who would have ever thought that that would happen? And similarly, you know, in many other areas, we have seen that minimally invasive procedures, either percutaneous or minimally invasive robotic surgery, for example, or others, would one day become the standard of care and the expectation. So we have always tried to be at the cutting edge. Similarly, right now with AI and machine learning, we have a number of projects that are ongoing within the Harrington Heart and Vascular Institute, both on the diagnostic side, but also on the therapeutic side. But beyond that, you know, what I'm most proud of, to be honest with you, because the technology everybody's interested in, but an area that we are very proud of and we have made a full commitment is the disparities and addressing the social determinants of health. And Dr. Sanjay Rajagopalan and many of our other colleagues here in Harrington HVI have really taken on this responsibility of trying to close the disparity gap. As you know, we received a $20 million Achieve Greater grant to try to address blood pressure and cholesterol in our communities here in Northeast Ohio with Dr. Rajagopalan. We have done a number of work with Dr. Elkendi around redlining and impact of social determinants of health on outcomes. we have been leading the efforts in identifying interventions that could potentially close the disparity gap as it relates to amputation. Now, honestly, LSAC was one of those initiatives that I mentioned earlier. So we are trying to confront all the challenges in the field of cardiovascular disease, whether it is a technical challenge or a new technology challenge, or it is disparities and social determinants of health, and also some of the behavioral. I'll be honest with you, right now we are working on a project, one of our colleagues, Dr. Bernardo Cortesi, who we recruited from Italy, they are doing a project on music therapy for during procedures, complex procedures for the patients, to see if the music therapy, this is not new. People have tried it for operations, but maybe even in the field of interventional cardiology could be useful. So they are doing a project around music therapy for patients that need procedures. So we are interested in trying to be at the cutting edge of research and innovation as it relates to cardiovascular disease, but not just in one specific area. It's very broad, and it can relate to not only devices and technologies, but also could be in a care continuum or disparities or behavioral modification and those kind of things.
Thank you, Dr. Shishibor. I really appreciate that because sometimes I feel like we often jump to the new device, the new technologies out there, but we don't think about those foundational things, those social determinants of health as well. So I really appreciate you bringing that up and bringing that into the discussion. In terms of focusing on social determinants of health, because I know we also have a question in the chat that I'll get to in just a moment about it. Where have you seen the most impact with the social determinants of health, with those behavioral foundations or social determinants of health, and how they impact your patients through research?
Are you asking me or yeah? I mean,
I think everyone can answer this question. Where you've seen this biggest impact in research, and then with your patients as well.
Well, I mean, I can take a crack, and please, June and Stacy, chime in. Listen, we have realized early on that a lot of times we make recommendations to our patients, but they're unrealistic recommendations. And I'm going to tell you what I mean. We see patients every day. Every cardiologist in our institute probably tells the patients, listen, you need to eat healthy, stay away from meat and chicken, and try to focus more on fish and Mediterranean diet. But at the same time, we know that these recommendations are not cheap. It's not cheap to feed 8, 9, 10 people with salmon and lobster and shrimps. So we tell people exercise. We say, listen, go for a walk, go and take a walk, be outside, go exercise. Well, some of our patients cannot afford to have gym memberships or don't even have the time or the transportation to get to a gym. Some of them live in neighborhoods that are not safe. So for us, the social determinants of health is really important in the sense that are these resources even available? At one time in my career, I was doing some research around availability of healthy food in some neighborhoods. And we were doing some geocoding and understanding the availability of fast food versus good quality food, nutritious food. And we saw, I never published the work, but that's a long story, But the point was that, we saw that there was a significant paucity of healthy food in some neighborhoods versus others. So as part of our clinical practice, we have to address these issues. I don't know if this is answering your question, but the bottom line is that the social determinants of health is front and center of our clinical practice, just like LDL cholesterol is, just like, coronary artery diseases. Like, in order for us to be able to treat our patients, we have to pay attention to the social determinants of health. I don't know, Stacy and June, any comments you have?
I agree with you, Mehdi. That's exactly correct. I mean, there's only so much we can tell the patient, but it's about implementation of what we advise, right? I can talk until my hair is all white about smoking cessation, but until we actually implement any of these changes at home, and we really need to empower patients to make these changes. It's ironic. I just saw a patient in clinic for coronary artery disease follow-up, and he had a bag of McDonald's sitting right next to him. So I think it's, I think Mehdi hit the nail on the head, which is we really have to start addressing it locally.
I would agree with what Dr. Shishabor and Dr. Lee said as well. And I think, helping them with their limitations, empowering them, I think is key, giving them the necessary education on their level. Like what works best for them, I think would make a huge impact.
Thank you, all our panelists, for answering that. Getting into more of a data analytics about this as well, Andy in the chat says that in the aspect of diversity, one observation that he has made, especially in retrospective studies, is that the representation or lack thereof of minorities. In several studies, even in big data from EHRs, minorities are often grouped into a bucket as other race. Can you explain how valuable secondary data and their findings still are to minorities who seem to not be keen on receiving medical intervention?
And rightfully so, to be honest with you. Like historically, as you know, Olivia, we have not done a good job. First, by losing the trust of this community, and then second, by, as Dr. Lee mentioned, we know that in medicine, in order to build trust with your patients, even clinically, forget about research, they need to relate to you. And we have disparities also in regards to gender and racial disparity of providers. Like, we don't have as many African-American cardiologists, let's be honest. And we don't have as many Hispanics. We actually have more Hispanics than we have African-American, female cardiologists. So number one is that we need to diversify, as Dr. Lee mentioned earlier, our portfolio of researchers that can build stronger ties and trust with their patients. So when they recommend these trials, the patients they have a trust and are willing to consider them. And second, we need to understand what those gaps are as it relates to trust and concerns that these communities have, and spend the time and the energy to explain those in a way that creates that trust and that commitment to be part of the research. And then third, to make it easy for them. As you know, clinical research requires a lot of follow-up. And many of these patients have difficulty. Either they have a hard time getting time off from their job, or they may have even a hard time with transportation. So it could be very discouraging, if you know that you have to come every month, every week, or every 3 weeks to be evaluated. That could be a big discouragement in regards to wanting to be a part of a trial. And then lastly, there are a lot of misconceptions, in my opinion, meaning that a lot of times patients feel like because they're going to a trial, they're getting the fake treatment. And as you know, that's not the case. And we just have to educate ourselves and our teams to make sure that they're doing a good job of representing the truth to our patients so that there's no misconception or myths about the project that we are engaging them on. I don't know, anything else, Stacy and June, that you guys want to add to this?
Yeah, I would like to add to this. To kind of echo what Dr. Shishabor said, I think it's important when you talk to any patient about clinical research and their families to use clarity, empathy, and understand their concerns from their perspective. Like to really have a thoughtful approach when you're going in to talk to them, put yourself in their shoes, treat them like family, and really it's important to make that personal connection. It's like Mehdi said, addressing the common misconceptions is a huge thing that we, patients continually ask when we're, talking to them about clinical research, but really emphasizing how they can make a difference and partnering with us. And, we wouldn't have the treatments we have today if we didn't have clinical trials. And letting them see that and giving a specific example that's personal to them. Like, for example, if you knew their family member went through cancer treatment, giving an example how, this treatment has helped other cancer patients in similar circumstances live longer, healthier lives. But personal connection, I think, is huge, and really going in with a thoughtful approach and explaining, I think, goes a long way.
Thank you. Dr. Lacey, you came off mute.
Yeah, 100%. I think it's so important. And my research team knows that sometimes I actually prefer to first address with the patient whether or not they would be interested in research before I even send in like the coordinator. It's because of that personal relationship that the provider has, because you established this trust already. And oftentimes the patient actually will say yes. And I've had fellows tell me, oh no, for sure the patient's gonna tell you no. And then, you just have to ask. They trust you as a clinician, they trust you as their doctor or their care provider to tell them, hey, I think you're a good candidate, and you, in an altruistic fashion, you're going to be able to advance our medical field and treat patients better in the future. And that's the end goal, is really to improve our clinical care for others.
Thank you, panelists. I really do love how you bring back this personal connection to our research participants and making sure that they are taken care of as a whole being, as opposed to just a research participant or a patient. So I really appreciate that insight. We have a lot of questions in our Q&A. Kind of keeping with this similar vein of, working with potential participants and with patients. We have two questions in the chat. I'll start with the first one of where should people go for heart health education? Are there spaces within UH for that? Are there interactive or online trainings? What educational resources or program does UH or Harrington Heart and Vascular offer for our patients?
I can take a crack at this if you like, June and Stacy, and you guys add. We offer a number of webinars, Olivia, through our cinema program. We are very, very fortunate here, to be honest with you. We have a very progressive and a very dynamic, multidisciplinary and creative program called Cinema, CINEMA, Cinema. And maybe June, you can put it in the chat if you don't mind. But Cinema program offers a number of webinars related to heart healthy habits, diets. They talk about lipids and risk factors. They talk about new therapies like the GLP-1, GLP-2s, and other drugs that are recently been out there regarding obesity and diabetes. So these webinars sometimes are attended by over 1,000 people. They've been very, very impactful. And this program has been nationally and internationally recognized. It was recognized as one of the top programs for cardiovascular disease and diabetes by the ADA, and has received a number of awards nationally and internationally for the preventive work that they do. So that's, for example, one example. We do offer a lot of webinars as it relates. Cinema is one. We've done this also around vascular. We do a lot of these around the condition called FMD, fibromuscular dysplasia, which can affect some people. So there are a number of webinars that you can join as it relates to Harrington HVI. So please look up in our website, and June put some links in there. Thank you so much. And but also beyond that, when you meet your doctors, you can ask them, and they will be also able to point you to some of those. In addition to this, we do a lot of screening. So I don't want to steal Stacy's thunder so she can tell you, but there are a lot of other initiatives that we are involved as kind of like a community outreach. So I don't know, Stacy, if you want to talk about that. And then maybe June, you can talk about some of the vascular stuff that we do around the screening and outreach.
So as far as community outreach, as Dr. Shapour said, we do a lot of outreach out in the community. We partner with American Heart Association, food banks, Cleveland Metropolitan Housing Authority, to try to reach that niche where it's hard to reach within the hospital. And that actually has been really instrumental for all of us, and not only helpful for the patients, but really rewarding for us as a team.
I was actually hoping that, Stacy, you can talk a little bit more about the Go Red that we typically do, because that actually is a lot of education towards the public regarding heart disease, especially in women.
Happy to talk about it. So actually this February will be our 21st anniversary of partnering with the American Heart Association. University Hospital's Harrington Heart and Vascular Institute is the local presenting sponsor. It's something I'm very passionate about. It's where we really, if for those that don't know what the Go Red campaign is, it's really increasing awareness for women's heart disease risk factors and really educating people. So we do events throughout the year. Our big event is typically in February, but we've kind of taken it a step further where we're educating the younger minds and hearts through their STEM program. Science, technology, engineering, and math. And that also not only gives us, tries to steer the younger generation into, those careers, but it also gives us an opportunity to educate them on cardiovascular risk factors when they're young, how to avoid vaping, healthier food options, teaching them CPR. So that has been, I think, has made a huge impact in the community, especially since we've had such a long-term partnership. And it gives us other areas of opportunity in the community where we wouldn't normally have.
And then from a vascular perspective, there's actually multiple different screening avenues that we have for vascular disease. And it's actually performed really locally. For example, within the last year, we had performed vascular screening events for the community in the St. John area, as well as in Lake. So we partner with our vascular lab technologists, and we do actually carotid screening. We do peripheral artery disease screening. We actually invite our podiatry program to help us out in terms of feet screening as well. So we have a very robust screening program, and it's offered locally, at least once a year, in different kind of aspects within Northeast Ohio.
Thank you. That was great to hear about all of your community outreach efforts going on in the area and some of that work that you guys have been going into. Giving us shifting a little bit with the questions that are in the chat. Someone asked, it was actually Holly Ma. She says, hello to you, Stacy. And she asked, how do we get more UH nurses involved in research and go beyond carrying out research protocols, but a part of the study team and publication? So really taking responsibility for the research in this question. And how can we increase nursing-led research related to the nursing care and practice? That is for you, Stacy.
So I would suggest one, partnering with an investigator to really help support it. And also the Center for Clinical Research here at University Hospital has a lot of resources and training available for nurses or young researchers to get involved and help with the IRB process, engagement, that kind of thing. That's what I would say would be a great start. But we definitely welcome any nursing-led research.
Thank you. And then I have another question in the chat from Kim Pollen. We've already touched on it a little bit already, but a question for all of our panelists today. What are some of the most promising recent breakthroughs in cardiovascular research at UH that have the potential to significantly improve patient outcomes?
I'm going to punt this to Dr. Shishabor, who finished out PROMISE last year.
Yep, I would agree. That's where you need to go, Mehdi.
Well, listen, there is a comment or there is a mission that we have embraced very intensely, and that's research is hope. And at the end of the day, yes, we like publications, we like innovation, we like to be at the cutting edge of technology, but there is nothing more joyful than having a technology, as Stacy also alluded to earlier in June, having an opportunity or a technology here in Northeast Ohio that we could offer to our patients around here. And I want to thank them both for giving me the opportunity to talk about this trial. But this was a trial that we started here for patients that had no options when it came to amputation. So these were patients that would have scheduled to lose their leg, to lose their whole leg. And we were the only site in the state of Ohio that offered this project for the past 8-9 years. And we were able to bring this research to Ohio, to Northeast Ohio, and we were able to treat many patients, not only from Ohio, but also from the surrounding states. Because at the time when we started early on, there were only 6 sites. There were 2 parts. There was a Promise 1 and a Promise 2. In Promise 1, there were only 6 sites in the whole United States, and we were one of the 6. And we are proud of that. We still have a few of the patients from Promise 1 that are doing well, and we interact with them and we see them. In one of them actually was that we did a Heart Heroes program, Stacy, right? Miss Elford, she's okay with us mentioning her name, and we did her case as she was our first patient about 8-9 years ago that we did as part of Promise 1. She had already lost one leg, and she was scheduled to lose her second leg, and we were able to save her through this research, this innovation, and she's still 9 years later. She has her leg, and she attended one of our events a couple of months ago. So there's been a number of, honestly, this is one of the studies, but this is, we continue to use research as a way to bring hope to our patients. We continue to bring cutting edge technologies and innovation and use it to try to save our patients' lives and improve quality of life for our patients. And I think Promise, the trial, interestingly, that research led to the FDA approval in October of last year of that technology. And now that technology is widely available across the United States. And that came from UH. I mean, that's something to be very proud of.
That's amazing. I have heard about Promise 1 and Promise 2 because I was lucky enough to see you at the Research Innovation Day about a month ago. And so you were talking earlier about HHVI being different, the fact that we collaborate with different departments and different teams across not just the system, but it seems also the country and the world. Can you touch on how Promise 1 and Promise 2 has done that as well?
Yeah, so not only the research itself allowed us to do that, but now that the research is complete and is now commercially available, we have more experience than almost anyone out there in the United States with this technology. So there are people that are reaching out from all over the United States that want to learn. Okay, how do you do this? How do we set up this program? How do we get to help our patients here locally that are at risk of losing their leg? So it has allowed us to engage at a broader level from that sense. Locally here, this is a new technology. So many of the podiatrists, for example, and wound care experts have limited knowledge about this technology. And this technology, the treatment with this technology is very different than what we do historically with other, approved devices and procedures. So we had to engage them to teach them how do you manage these patients that have had this procedure, because the treatment is very different. So this led us to, with Dr. Lee's support, to create a bi-monthly educational meetings, events, where we have 70, 80 podiatrists get together and go over cases like this with this new technology and how the management of these patients are. Now, this allows that collaboration. So not only we get to teach them, but they get to know us. Next time they have a patient, they know how to engage us and work with us to try to take care of those patients. So it's been a win-win situation, to be honest with you, in a sense that it has allowed us to collaborate nationally and locally with various organizations in trying to help patients. And we want to continue to grow these programs and these collaborations.
Thank you. It seems like it's already doing a lot of growth right now, and I wish you guys the best of luck with growth in that in the future. Dr. Lee and Stacy, are there any other groundbreaking or new research projects that you are working on that you can see having impact on patient outcomes in the next few years as well?
Well, it's biased because Mehdi and I are both endovascular people. But certainly aside from LimFlow, which was the company that supported Promise 1, 2, and 3, also we have clinical trials that we are starting soon, looking at below the knee drug-coated technology. And that's an area that is really is missing a tier. We have drug-coated technology in the coronary arteries. We have it in the above the knee segments, and the drug-coated balloons actually are intended to help prevent scar tissue formation, helps the longevity of our intervention. And below the knee, we simply just don't have the technology right now to help patients essentially stay out of the cath lab, stay out of the OR suite for repeat procedures over and over again. So we're actually very excited about the new clinical trials that are coming up because we think that it will be impactful to our patients with chronic limb-threatening ischemia.
Dr. Lee is very humble. I can tell you that, about 8-9 months ago, first of all, she's the national PI of a technology to treat pulmonary embolism. So these are patients that get blood clots in their lungs. As you know, pulmonary embolism is the third leading cause of death in the United States and is the #1 preventable cause of death in the hospital. And she's she's a national PI of a trial with a new technology. But that itself is huge for UH and for Northeast Ohio and for us here in this community. But she performed the first patient with this technology in the world, the first patient ever done anywhere in the world with this technology, which is a third-generation technology to treat this condition, with this deadly condition, pulmonary embolism, was performed here at UH by our own Dr. Lee. So, there's a lot of cutting-edge stuff happening here. Like I said, you could go for a few hours, but there's a lot going on, and we will continue to push the forefront of this research and innovation. And Stacy obviously has a lot of other stuff that I'm sure she would love to talk about. Some of the valve stuff with the mitral valve and tricuspid valve. And I don't know, Stacy, anything else you want to highlight?
Yeah, so in our structural heart center, we actually, as Dr. Shishbor alluded to, we're doing a lot of different areas that we haven't done in the past, like tricuspid, mitral, different approaches. So that has a lot of promise for the future as well.
Well, thank you all for sharing about the research going on in HHVI. We are getting to the end of our webinar. We have about 8 more minutes for questions. So if anyone else has a question, please put it in the chat for us in the Q&A. I do have one question from maybe a potential participant asking, if they are not in Northeast Ohio, how can they start to participate in studies? What would you suggest for them?
That they reach out to us. We try to make anything happen, anything possible. I mean, Dr. Shishbor and actually Dr. Lee as well have patients that come from out of state to participate, and then we do their follow-up remotely. So I would encourage them to reach out to us. Happy to give them my contact information.
All right, thank you. And then another question is going to be for you again, Stacey. I apologize to have you answer again in a second, twice in a row. As an experienced research professional, you are the director of the clinical trials unit. As you mentioned earlier, you've been doing clinical research for 25 years. What have you noticed working with young investigators and research staff who are new to the profession? What about this work is enjoyable for you as you are, working with the next generation of investigators?
So thanks, Olivia, for this question. This is one of the things that I love doing the most. I really enjoy it. We love seeing the enthusiasm. We really want people to go for it, like not be challenged, not to take that initiative. We love seeing that adaptability and their openness to try something. I'm a firm believer that if it doesn't challenge you, it doesn't change you. We try to give either young investigators, new research staff, anyone, to foster their learning, to have more critical thinking, to hold them accountable, because it really helps them in the long run. There's nothing more rewarding to me than seeing someone that, either worked under us or worked with us side by side succeed. So, it's important for people to take that chance. We've developed long-term relationships. We love seeing, either some of our interns go into med school or publish a paper, or we had one of our research interns that work with us is now in his residency here. And we just love seeing the success. It gives us a lot of pride and satisfaction, and we encourage people to take that chance.
Thank you, Stacey. And this is for everyone as well, kind of jumping off this point. What would you suggest for a new researcher who's never done research before in their life, or maybe are college students who want to go into medicine, or someone who is changing careers? What would you suggest for them to get involved in clinical research?
I think the first step is really to identify a mentor, somebody like Manisha Shimor.
Exactly.
So somebody who's very well experienced in research and knows exactly what goes into clinical research. And I think identification of that mentorship is very important. When I was actually, my own personal story is I really loved endovascular actually as a medical student. So when I started my intern year, that's when I actually sought out my very first endovascular attending. And I started really early, because I already knew my pathway. So I think it's so important to identify the right mentor who is going to be in your corner and be with you. It's going to be, there's a lot of work usually involved with research, and we know that. So having somebody guide you through that pathway is important.
I think June said it very nicely, and I would say on the other side of it, I think the reward, I mean, for both of us and also Stacy, all of us, uh, I can tell you that it's one of the most, if not the most joyful part of our work. And also it gives our work some diversity because, it's seeing patients is great and is awesome and we love it. It's the core to what we do. But it's also nice to have that scientific, academic, innovation aspect to the work because, you want to have some diversity of work. You want to be able to sometimes write something. You want to sometimes be able to get on the podium and present your work, and you also want your work to impact many, not just the patients that you see every day. So if you have opportunities, that's why we do it, because it does allow us to have a broader kind of a portfolio of the things that we do that we love, but also have a bigger impact and also learn from others because we learn from others. When you are doing research, it's very rarely just you are working with a team across United States, across the world, and we learned a lot. I mean, through this Promise experience and other research, we have learned so much. We made new friends, we learn new approaches, we talk with other people, we make new relationships, and so on and so forth. So there's a lot of benefits that comes out of the research. It sometimes can be hard because we are busy and we have other responsibilities. We were just talking about that this morning with Stacy. But the rewards definitely outplay the some of the hard work that you have to put in and are obviously very impactful on the patients and on the entire healthcare.
Thank you. I love hearing about the different ways people can get involved. Dr. Lee, thank you for your story about finding your first mentor and getting started. And just thank you overall. We have time for one more question. And so I would like to ask all of you, just to close us out today, a more personal question, especially as we're going into the holiday season, people have more time. What is a podcast or a book that you recommend to the audience that has been your favorite this year, whether it's about cardiovascular research or something that you just want to shout out for our audience today?
I only do audible books. I don't do podcasts.
Well, I do podcast. I do podcast, and I listen to a lot of podcasts. And but I rarely listen to healthcare because I feel like I know enough in healthcare, so I listen to other things. um, but there are good. I mean, I'll be honest with you. I think if you exercise, if you do other things that you can listen while you, what it is a good way. And I'm not a fast reader like Dr. Lee, and so I do like to listen to things. So I do think there's a lot of podcasts. The one podcast that has been helpful, one of my own friends who we actually invited to do a short presentation, Dr. Huff, who did a presentation for us. He does have a podcast about uh, uh, healthy habits and fitness. And his last name is Huff, Huff. First name is Christopher, if you want to look him up, Christopher Huff. And he has had a number of, he's an interventional cardiologist. He was actually one of my former residents and fellows, and he's now has decided to commit part of his career to improving people's health, which is awesome. So he does have a podcast. He actually has a company now that he coaches people how to become healthy and build endurance. And I have no conflict, by the way. I don't get paid anything for this. I'm just, he's a friend, and I'm just telling you. So I have listened to a couple of his podcasts just to see how he's doing, and I think they're pretty good actually. He has good guests, and they talk about endurance and diet and health and nutrition. But there are many, many out there, to be honest with you. If you find good ones, you can learn a few things about health and cholesterol and diet and so on and so forth. I don't know, Stacy, if you have any podcasts you recommend.
So I'll be honest, the first podcast I ever listened to was Dr. Huff after our Institute meeting. You had recommended, he spoke, we have a wellness initiative in the Harrington Heart and Vascular Institute, and as Dr. Shishabor said, Dr. Huff came and spoke. And I found his talk very interesting, intriguing, and really encouraged me to learn more. So I have listened to a couple of his podcasts, first ever that I've ever listened to. So thank you, Mehdi, for that. But the other thing I would say, recently, a friend of mine actually wrote a book, and it's actually will be available starting Saturday, but I had a chance to read it before it was published, and it's called Picking Up the Pieces. She lost her husband to sudden cardiac arrest, which is something that, is very important to me, and educating people in CPR. So I encourage people, once the book comes out, to read it. It's really enlightening, and it not only for losing a spouse, but also things in your life that I think it would be impactful.
That's great.
And I'm not getting any royalties from the sale of her book either, but I just think it would help a lot of people.
Well, thank you. Sad to hear you guys aren't getting any sponsorships from those shout outs, but
Yeah.
Thank you so much for your recommendations, and thank you so much for being here with us today and taking the time to talk with us about the incredible work you're doing, the importance of your research, and most importantly, the role that research is going to play in shaping medicine for the next years to come. For our audience, thank you for being here with us today. I always love hosting these webinars, and please join us next time on Thursday, March 20th, 2025 for our next Discover with UH webinar as we highlight sleep medicine at 12 p.m. Everyone have a great week, a great weekend, and please stay warm. And thank you again to our panelists. We've loved having you. Have a good one.
Thank you.
Thank you.